Am I good to begin? So good afternoon, everyone. I'm happy to be here today to talk about my experience as an embedded researcher within the Algoma, Ontario Health Team in Northeastern Ontario. I'd like to quickly acknowledge and say a big hello to Jeff Dorans, Cassandra Lepore, and Erin Mulrooney, and the rest of the AOHT Transformation Office who are on the call today. It's not advancing. The slide won't. Oh. What did she do?
It was just on the wrong screen.
Oh, okay. So with my time today, I will situate the Algoma Ontario Health Team, share my initial thoughts about challenges facing OHTs, opportunities to advance the OHT through through research for evidence-informed decision-making, and how I initially thought about approaching this prior to joining AOHT. Highlight the intersectoral approach I use for relationship building, networking, and stakeholder engagement, as well as its continued importance to conduct applied research in the region, and highlight some work within the proposed research program initiated during my placement, as well as some related challenges and successes. So when I was at AOHT, it had 14 partner organizations and several collaborators representing health and social services across the region. Now, I say this recognizing that AOHT, like all other OHTs, are transitioning to an incorporated governance structure. The total region covered by AOHT is approximately 32,000 square kilometers and represents nearly 103,100 community members, over 30% of which live outside the population center of Sault Ste. Marie. The city itself is an isolated, mid-sized urban center surrounded almost exclusively by rural and remote communities. When envisioning a potential program of research, the first question I asked myself was, what challenges needed to be addressed, bearing in mind the EOIs, identified priority populations, and projects? Prior to my becoming an Impact Fellow, OHTs in Northern Ontario faced several challenges, including balancing numerous and diverse perspectives, health and situational vulnerabilities, conflicting and competing interests of culturally and linguistically diverse populations and communities who have been historically subjected to social exclusion that are spread across vast vulnerable geography. Transitioning from identifying priority populations to patient attachment and appropriate effective engagement and outreach to identify care gaps. Access issues for in-person and digital health services, many of which contribute to health inequities. And these include physical and geographic barriers, broadband internet access, access to technology, and digital health and literacy. And transitioning from pandemic response to recovery. And this requires evaluating population health impacts, assessing resource and system requirements, managing service disruption backlogs, and adapting to changing workforce conditions. So this slide illustrates my proposed vision for applied primary care health policy and services research, emphasizing rural and northern health systems. I took this to my OHT host mentor, and together we compared this with and adjusted to the AOHT's program of work to see which of these would be feasible for me to initiate during my placement, with the aim to advance the OHT through research activities that support the quintuple aim. Now, I acknowledge that while equity is not pictured on this diagram, it was an overarching principle to approach and a desired outcome for everything that we did. To improve the provider experience, it was envisioned that practitioner-focused research could provide invaluable insight into what professional, personal, and policy factors drove practice decisions, workloads, and ultimately care provision in a context with chronic provider shortages. To improve population health, it was envisioned that patient and community-focused research could use deliberative dialogue, participatory evaluation, and appreciative inquiry to facilitate understanding, engagement, and trust to co-identify priorities and design projects. To reduce healthcare costs, it was envisioned that engagement and research could provide valuable insight into supply and demand side, financial and other costs of providing and receiving virtual care and digital health during this unprecedented time. And to improve patient and caregiver experience, it was envisioned that team processes could use critical reflective practice and promote a dialogic culture for quality improvement. They could engage various sectors to generate creative solutions to identify, address, and advocate for workforce and resource forecasting and planning. But I would be remiss if I did not mention that initiating this would not be possible without an openness to and support of research to produce evidence to inform decision-making at AOHT, as well as incredible teamwork and collaboration within the Transformation Office. It was wonderful to collaborate with colleagues on projects and initiatives already in progress, led by them and community partners, such as their Test of Change program, their Community Wellness Bus program, and their post-fall pathway within their healthy aging portfolio. Spanning over 800,000 square kilometers, representing 88% of Ontario's landmass, Northern Ontario's vast geography has 8 urban population centers separated between 150 and 450 kilometers of wilderness. In anticipation that many of us placed in rural, remote, and northern areas were experiencing the same challenges and having similar conversations, some of my colleagues and I who were placed in these settings began to meet monthly to discuss common challenges and shared learnings. And we were very fortunate to have Rob Barnett, Cohort 1 fellow, join us whenever he could during his busy schedule. So thank you, Rob. I personally found this to be very helpful, and hope that as more fellows are placed in rural and remote and northern OHTs, that a critical mass of expertise in and for these unique contexts can be built to benefit OHTs and their partners. So while Northern Ontario is quite large in size, its capacity is small and isolated to do this work. And one of the challenging things for us was that we weren't always sure if what we were talking about doing wasn't duplicating current efforts. Being as under-resourced as we were in the region, with an even narrower focus on Northeastern Ontario, we didn't have the luxury to reinvent the wheel or compete for scarce resources. Our preference would be collaboration and cooperation. We also wanted to avoid talking past or working at cross purposes with one another as potential partners, as we work to strengthen existing and developing new relationships. So to carry out research at AOHT, I spent much time initially networking and establishing stronger ties and partnerships with universities, colleges, and research centers in the region before branching out to partners in other sectors. One consideration for this was Research Ethics Board access, depending on the study design and methodological approach of a particular project. But networking, relationship building, and exploring intersectoral collaboration went beyond exploring research collaboration. In these meetings, we also discussed participation in research as contributing to primary care engagement strategies, contributing to continuing professional development of providers in AOHT's catchment area, and ideas that would mutually benefit graduate programs and their students and the OHT. So this research program vision discussed earlier began with a single project. A conversation with a primary care provider highlighted the importance of understanding primary care and allied health experiences and needs for pandemic recovery. It inspired a project to improve provider experiences. It was hoped that primary care and allied health involvement could lead to increased engagement and partnership among local stakeholders, and the co-identification and design of priorities, future projects, and initiatives. Findings could have assisted AOHT and partner organizations to identify current and forecast future service and resource needs and to provide care in the region. There was also potential for findings to be used to inform policy advocacy efforts. But unfortunately, due to participant recruitment challenges, we were unable to proceed with this project. Primary care engagement in this instance was a challenge because of the understandable limited capacity of local providers. In addition to experiencing severe burnout, there were concerns that patient care would be compromised due to a lack of coverage and other practice support, and that they would be unable to fulfill their teaching commitments. Noticing that the same individuals were repeatedly called upon to be involved, we frequently discussed how to strike a balance between increasing involvement and not disengaging those actively involved in AOHT work. We also discussed the importance of clarifying and specifying asks for involvement in project work. But one thing that I increasingly thought about as my fellowship was coming to an end was sustainability of the work that I started or was involved in. We secured local project-specific collaboration and resource access, but access to these resources long-term was uncertain. Shortly after the pandemic started, where care settings restricted visitor access, the Ontario Caregiver Organization launched the Partners in Care Pandemic Toolkit with the focus on caregiver ID, communication tools, and tips to enable the safe and meaningful presence of caregivers during COVID-19. Hospitals, long-term care homes, and other settings have leveraged these resources. Sault Area Hospital in Sault Ste. Marie was an early adopter of caregiver ID, and approximately 550 caregivers have participated locally since its inception. In consideration of the unique needs of more geographically isolated caregivers, and with the intention to expand the reach of caregiver ID, this research, in partnership with Algoma University, Sault Area Hospital, and the Ontario Caregiver Organization, sought to explore the post-pandemic needs of caregivers in the Algoma district to better understand the supports and/or resources needed in local communities. This project was a successful example of community engagement, partnerships, and intersectoral collaboration. We worked in partnership with patient, family, and caregiver advisors affiliated with Sault Area Hospital to co-identify and design the project. They were involved throughout the project as full team members and are playing a pivotal role in knowledge translation activities currently in progress. This project also helped us to understand a segment of AOHT's population and to identify potential advocacy efforts to address needs identified in the study's findings. Partnership on this project was formalized with a memorandum of understanding, and relationships between AOHT, partners, and caregivers were built and strengthened. The overwhelming community response led to local media coverage, which boosted participant recruitment. For example, on a weekend, as a result of the Sault Today publication, we received 20 participant registrations. Algoma has a highly engaged community membership, and we received inquiries from partners to discuss the potential to initiate other projects reflecting community priorities, which could assist with population segmentation. I'd just like to thank everybody for their time. Thank you also to Angela, Patrick, Megan, and Ross for the opportunity to share my experience today. And thank you to the Algoma Ontario Health Team, particularly the dedicated and passionate Transformation Office and its community partners for embracing me and for making my experience as an embedded researcher a positive one.
Great, thanks so much, Sophie. If there are any quick questions for Sophie, we have a minute or two for that, and then while our next set of presenters gets organized. So there's some things in the chat. Thank you, lovely pictures.
It's great to see you too, Cass. And Jeff.
All right, if there are no immediate questions, we'll have our next presenters come up, and we'll invite Sophie back at the end for a bit of a panel discussion. Okay, so next up we have Grace and Brianna. This. All right, and hopefully I will be more successful this time. So many screens to coordinate. All right. All right, so you're gonna look into this. So the camera. Yeah, and so they will be presenting about their work from two different OHTs and looking at data integration.
And then do we just advance the slide on this one?
Yes, you should be able to do that.
All right, so hi everyone. Grace and I are very excited to be able to speak with you all today about some of our work with Ontario Health Teams. Today we'll be talking about developing a patient-focused integrated data dictionary and repository and walking through that process towards data integration into Ontario Health Teams. And I will warn you in advance, at the end, we have a small survey for you. So keep your phones handy so that we can do both the survey. We're going to try this online and in person. It should work, but just have your phones handy for the end.
Wonderful. And as Brianna said, we were both postdoctoral embedded research fellows within the OHT Impact Fellow program. But other than this, we don't have anything else to disclose. So today we'll begin with a little brief background on what are Ontario Health Teams, although I know this is a very familiar term to this group. We'll talk about the methods behind developing our data integration approach, and specifically outline the data dictionary, the data repository, and data dashboard, terms that will be familiar to you in a moment. We will share some of our lessons learned along the way, and finally show our upcoming toolkit, which will be available to you shortly.
So first, we just wanted to give you a brief overview of OHTs, although I think most people in the audience are quite familiar with them. So OHTs are a relatively newer model of organizing and delivering care in Ontario that are focused on integrated care and using the quadruple aim. So with OHTs, there's this focus on focus on population health management to provide high quality and equitable patient and population health. And I think for many, focusing on populations in that upstream preventative lens to include both users and non-users of the health system is one of the biggest shifts for providers and OHT partner organizations. So for Grace and I was in the Berrien area OHT and Grace was in Northumberland. To achieve these goals, the OHTs have their attributed populations. So you'll just see sort of a graph, our maps up there for our OHTs to kind of give you an idea. The Berrien area was cohort 3 with an attributed population of 192,000, and Northumberland OHT had an attributed population of 51,000 and was in cohort 1. So OHTs have various needs depending on their cohort and level of maturity, but for many common goals and challenges exist. So just wanted to highlight for example, all OHTs have the mandate and desire to engage in that population health management, but in order to do this, you need to truly grasp the complexities of your population and engage in segmentation or separating out your population into distinct groups. And although you can do that segmentation with higher level data, that includes provincial census data, you really need to ultimately be able to tap into your local data and delve deeper and identify or better understand your priority populations in a meaningful way to direct your future work. OHTs also face the feat of doing evaluation, QI, research, and health literacy capacity at the local level, which can also be a common challenge. And finally, OHTs are mandated to partner with organizations across numerous sectors. And although these sectors and organizations have partnered before in numerous different capacities, they rarely have an understanding of each other's local data availability and are not sharing their data. So it's important to have that understanding. And then central to all of this is this intersection of data itself. So supporting data capacity by developing a dynamic mechanism to understand what OHT partners are collecting and identifying gaps is really paramount, which gives rise to the data integration process. So the data dictionary is sort of a way to address this gap.
So we'll share a little bit about our methods in developing this data integration approach. We first set out to the literature to see what was available in terms of data integration within the integrated care space. And there really was a paucity of data, a real gap in information on data integration and integrated care. What we did find and what we did lean on were conceptual frameworks of integrated care, really to situate that data integration need and overall data capacity need within the integrated care space to help us understand some of those intersections that Brianna described on the previous slide. In addition, we examined other regional approaches to merging data sets among various partners and other approaches to selecting and prioritizing measures for key performance indicators and adapted these into our approach. And finally, we refined and confirmed our data development data integration approach in consultation and collaboration with our stakeholders at each of our OHTs. So before we go any further, we wanted to share our operationalized definitions of some of these key terms that you will be hearing throughout our presentation. So we refer to data integration, as you can see, covers the entire space, as this seamless, dynamic collaboration between data sources, storage, and utilization with combined patient-centeredness goals and supporting overall data needs of an OHT. And then within data integration, we've highlighted 3 key steps or tools to reach that optimized data integration. So the first of these tools is the data dictionary. What we're referring to here is the most robust overview of the data. The dictionary serves as an index of all of the indicators collected by partner organizations and then cataloged by type and availability. As we move toward a data repository, this is a more refined data tool. And here we are talking about a data storage tool for selected key performance indicators from partner organizations intended to move priority population work forward. So we move from having an index to actually housing data in the data repository. And then finally, the most specified and refined data tool is this data dashboard, which is a mechanism to display a highly specified set of indicators that are frequently monitored and refreshed for live tracking and ease of use and access for OHTs. So we're moving from the most robust big picture with the data dictionary to a highly refined specified data dashboard tool.
So ultimately, all of the work on the previous slides led us to develop and venture into this data integration process shown here. So this roadmap serves as a visual representation of that process, moving from the initial dictionary through the repository and then to the eventual dashboard. And when we're talking again, like Grace said, when we're talking about data dictionary, we're starting with indicators and then we move to the actual data itself. Because implementation was between 2 different OHTs, there existed a lot of variability in differing levels of maturity and states of readiness, but many commonalities existed as well. So we'll highlight those as we go through. So the first step was in building the data dictionary was really to engage in OHT partners, and we can't emphasize enough that how important building that trust and establishing a working relationship with the leadership and data contacts at all of the OHT partner organizations was to create a buy-in to the process and for the ultimate success of the project. It was time consuming, but absolutely essential in the process. The next step was to formally identify the current state of data collection in each organization and understand what they sort of envisioned as their future state and how they sort of saw themselves being positioned within the OHT. The goal here was to understand how each partner organization collects, stores, and shares their data currently, if they were patient-facing, what EMRs did, so all of the intricacies of what they're currently using to house different forms of data, and then what their future goals were. The third step involved receiving indicators receiving them from the partner organizations. And there was great variability in the indicator volume and the type from the partner organization. So some organizations didn't have lists that they had. They submitted instead executive reports that you teased out indicators from. Whereas others shared thousands of indicators that they're collecting on a wide scale. So it was very varied among organizations. So then the next step was obviously to synthesize all of that information into a more concise table. So it started as a very messy table, and then you come into really synthesizing it and looking at themes, and then aligning that with the strategic direction and priority populations of the OHT that we were at. And the goal here was to have a more manageable amount of indicators that were relevant to the OHT as a basis for selecting the future key performance indicators. And then that fifth step was after synthesizing indicators with the OHT strategic priorities, we really wanted to refine and extract a selection of indicators from the dictionary for the repository. And that involves extensive stakeholder collaboration within the OHT. And the goal here was to have a manageable number of indicators that the OHT could then go out and get the current data for that would be meaningful to that OHT.
So bringing us along to step 6 here, when we actually transfer the data. So in transferring the data from collaborating partners, it's really important to previously establish data sharing agreements, privacy considerations, and this requires consistent, timely updating of aggregate data. So there's a lot of background work that goes into this 6th stage to have the capacity to be able to house the data ethically and privately. Then we move on to actually selecting those data dashboard indicators. So this is the most, again, refined, specified piece. So these are the indicators that will be updated and have live tracking so that OHT partners can review these absolutely priority indicators and have a live dashboard to be able to check in. Now, while the data dictionary represents the most robust overview of the data, as I said before, this dashboard is this highly specified set of indicators that are being monitored and refreshed for live tracking. So once the capacity of the dashboard is up and going, this digital platform will house this dynamic data, and you'll have to have capacity underway to continue to pull the data from the repository for the dashboard. To keep up with these shifting and evolving strategic priorities of the OHT, continuous engagement will take place with the collaborative partners to have iterative adjustments in both the in all stages, from the data dictionary, updating the entire index, the data repository, those key data elements that are being refreshed and updated, and then finally that live dashboard so that it continues to reflect priorities as they ebb and flow. And then finally, with 10 being the ultimate optimized data integration, the hope is that the data will provided in all 3 components of the tool, the dictionary, repository, and dashboard, will encourage evidence-informed decision-making and data integration to transform OHT priority setting.
So there were many deliverables that resulted out of this whole process. One is an asset map. So we just wanted to use one of these as an example. So this is an important visual component that the OHTs found useful in terms of using it for working groups and understanding the key domains across OHTs and understanding what's currently held and what could be used at a glance. So in terms of lessons learned, from my perspective in a cohort 3 OHT, there were some key points. The first was being able to help the OHT understand commonalities and differences between various metrics in order to move toward eventual integration. So although some organizations may collect similar indicators, definitions and parameters often differ. And in many ways, it's through that data dictionary that we sort of came together and we're starting to speak a similar language and understand where there were some gaps. Another lesson learned was the need to develop some separate pathways that aligned with the OHT strategic direction and priority population in order to help the working groups identify local data more readily. So where was the data, what was already being collected, and what would we need to collect ourselves or get from different sources. And finally, getting patient, family, and caregiver, clinician, and leadership involvement and perspective to help drive the key performance indicator work was identified early as imperative, but also proved to be somewhat of a barrier due to resource and expertise challenges.
And from both of our perspectives, but certainly my perspective as a cohort 1 OHT, we really found that the variability in both topic and level of detail in the health indicators collected revealed the need for an equally adaptive data collection tool for integration. So the deliverable that's shown here, the asset map, was one of those. Oops. I did on the wrong one. The asset map shown here was one of these adaptive tools that we made along the way to bring together this highly variable indicator sets from the different OHTs. And we also found that the collective data inputs provided, though very variable, afforded the OHT an enhanced understanding of the various strategic directions of collaborating partners to better understand the unique needs and priorities of each of the members and fully inform the strategic direction of the OHT as a whole. So the next steps involved in this involve the dissemination of our toolkit, which we've alluded to, and it's based off the roadmap that we discussed, and this will allow other OHTs to learn from the work we have done in order to spread and scale across OHTs, this data integration initiatives, and continuous engagement with other OHTs to help build capacity and spread and scale this work. And that could include engagement with some of you in the room here and some of you online, so that we can continue to go about this data integration work. So this toolkit that we've been alluding to, Brianna and I had the opportunity to extend our fellowship work to really develop knowledge tools coming from our experience, specifically a toolkit to support OHTs facing these similar challenges and to enable them on a path forward. The intended audience for this toolkit is for OHTs, partner organizations, health system leaders, collaboration council members, and researchers, just to name a few audiences. And the toolkit is comprised of a guided pre-recorded webinar where we go through each of these steps in detail. We use a case study as an example to give you a realistic and applicable example for each of the steps to give concrete examples. We also include interactive templates like the asset map shown and others that can be used, and describe the people and resource constraints needed at each of the stages of the roadmap.
Okay, so if you're able to take out your phones, we'll go through thank you and questions, but you can do this while we're doing it. So you just go to menti.com and enter the code, and it will just take you through the questions very quickly if you can do that. And I'll leave this up for a second. Or you can also point to your phone at the screen and just do the QR code. And it will take you right there. Sure. So do you want me to?
We could share.
Oh,
Sorry, that was this one. I meant to click it on the other one. Too many computers.
I think in the interest of time, we won't go through each question. So if you wouldn't mind just completing that on your own as we continue with the final takeaway and the thank you.
Just show one.
one.
Maybe.
Sure. Or we'll show you one or two. How do we show it? No,
Oh, view results? All right.
how do I put it on?
So this is the,
This is showing.
oh,
And that'll go over. No, so computers. Okay, so share Menti screen.
We'll take a look here. Perfect. So it looks like we have a good amount of OHT Impact Fellows, some OHT staff partner organization and staff, and some others. So let's see what some other ones are. Project and Quality Improvement Lead, Program Team. This is great. Thank you. Thank you for putting this in. So when we asked about, does your OHT currently have a data evaluation framework? So this is what we expected. The majority do not have something formalized. And if so, is data integration part of the plan? So again, of those that are, only 3 have data integration as part of the ultimate plan. In terms of key performance indicators included in your OHT strategic plan, this is about what we expected since a lot of it is part of a TPA. So you have formalized ones. There are the majority too. Doesn't want to go on. There we go.
Okay.
So which data and evidence resources do you currently most rely on? So we just wanted a snapshot of what people are currently using. So this is really interesting. We expected HSBN and Inspire, the data dashboard from OH. Not as many are using IntelliHealth on a regular basis. And it looks like some are accessing local data that's being housed in partner organizations, which is great. And quite a few are actively collecting, which is wonderful too. So this is a great snapshot. Thank you. And project specific. And then would a data integration tool could be of value? Yes. And then preferred mobilization, so an online toolkit and individual OHT meetings. So that's something that we can definitely explore as well. So this is great. Thank you very much for filling this out. Greatly appreciated. Is there a way to go back for the final slide? Sorry, Pat.
Yeah. Sorry, we got one more slide. Sorry, yeah. So just for the final slide, it's okay.
Much anticipated.
I know. Here we go.
I think it's this one. I think so.
Okay.
Okay, so a final takeaway and then we're done.
Takeaway, much anticipated, really is that this data dictionary process and ultimately data integration process we've described can be a key enabler in helping OHTs achieve their goals of population health management and priority population initiatives as illustrated throughout this presentation. And the process that we've described today will really evolve as OHTs mature as an iterative and dynamic process. And we look forward to connecting with some of you and your OHT data processes to better understand the process as well. So thank you.
Thank you. So a big thank you to our Ontario Health team. So especially our OHTs, the Barrie Area OHT and Northumberland. And thank you to the OHT Impact Fellow Program and all of the IHPME staff and faculty who have been mentors and supporters. So thank you, everyone.
Thank you so much. Thanks again to our presenters. Our final presentation for the day is coming from Reham, who is in our first cohort of fellows, Burlington OHT, and has continued her work advancing research and evaluation and quality improvement there. So I'll pass it over to you, Reham. And hopefully you should be able to share your screen.
Let me try.
Yeah, see if that works.
Are you able to see my screen?
Yes.
Is that like full screen now?
Yes.
Okay,
Looks-
great. Hello. I know you're probably very tired and probably very hungry as well. So I promise that my presentation is going to be a little bit different. It's just a story. I presented on my work with the Burlington OHT in the last 2 years or 2 events, just because I'm from cohort 1, as Patrick just said. So today I thought that maybe because I'm one of the few OHT fellows that continued working in the same space, which is OHTs, I thought that maybe telling my story and like walking you through the trajectory of like, since I started as an OHT fellow and where I am now, might be of interest to some. So a little bit of background, because it's my story, so it's going to be about myself. So I came to the OHT Fellowship as a health services researcher who just finished her PhD at the HPME with a specialization in evaluation of complex interventions. And my research focused on evaluation of integrated care with a special interest or focus on using care experiences in evaluation of complex interventions, co-design of complex interventions, and also studying planning and implementation of engagement policies and strategies. Beside that, I had a very strong passion to improve people-centered integrated care in Ontario, as all of us have. But because of my clinical background, I've often had this clinical mindset of evidence-based knowledge. Always knowledge has to be created within research and within universities and then transferred somewhere else. And I was looking at having a wide-scale impact. In September 2021, I joined the Burlington OHT as an OHT fellow, and my title there was evaluation lead. I came to this role with 3 main goals at that time, is to apply what I have learned, understand how does it look on the other side, which was for me the practice because I was never there before, and also to widen my network. I was very pragmatic in the way I was thinking. I was thinking that, as I said, knowledge needs to be created within research and then transferred to the practice where they need to adapt it, and then they will feel happy and everything will be right. My simple academic background mindset at that time looked at evaluation as create a logic model, create an evaluation framework, have an implementation plan for your evaluation framework, have the tools that you need, do the analysis, present the results, and then provide some recommendations for a decision or a change. And that's all, easy and nice. However, the part about this fellowship that I didn't think about a lot before was being embedded. I'm not an external evaluator anymore. With that comes lots of change. The biggest word that I needed to learn was context. With the context of the OHTs, lots of complexity come to the evaluation. Creating logic model was one of these. But there were other areas of complexity. First of all, I don't just need to evaluate programs or policies or initiatives. Actually, I need to evaluate everything, programs, policies, and initiatives. Plus, most of the OHTs don't have an evaluation team. So I have to be the team or find a way to create a team. Also, different policies and programs and initiatives are at different points of implementation and maturity. So I need to match the evaluation plans and tools to the maturity level of each intervention that I am actually evaluating. However, each intervention is run by various organizations. So this culture thing that needs to be built before you are implementing any evaluation plan was really tricky because I'm not doing that with like one provider or 2 or 3. Some interventions were up to 20 organizations that I have to convey a message, gain a buy-in, and then work with them to evaluate the program because, again, there was no team, so I have to create a team. Each of these organizations has their own reporting requirements beside being part of the OHTs. And each evaluation that I am conducting needs to be linked to OHT strategic plans and OHT strategic KPIs. Okay, is that enough? No, because one interesting piece is that there are no DSAs, data sharing agreements. And why there are no data sharing agreements? Because OHTs are not entities yet, so they can't sign DSAs. And above all, whatever I'm doing needs to make sense from a population health management perspective, which is the main driving factor for anything that's happening within the OHTs. So I started to kind of reset my mindset again. It's not about creating knowledge within the research area or like research environment and bring this ready-made solutions to the practice and asking them to take it. It's more about understanding the intersection between research and practice, how each one of them can learn from the other, how can they collaborate to create knowledge that is evidence-based, but also can be implemented successfully in a practice environment. So I start to act like an embedded. What does this mean? In terms of evaluation, this means that I need to build a culture of inquiry and evaluation, not just reporting. I need to provide training on how to formulate an evaluation question, how to collect data, analyze data, sometimes how to use an Excel sheet, and how to use this to provide a guidance for decision making. I also need to learn that, at that time I needed to learn that one size in general evaluation doesn't fit all. Sometimes it doesn't even fit all the organizations within the same intervention. So tailoring was key. And when I'm talking tailoring, this took lots of time and effort in terms of understanding the individual context of each organization as an entity, and then their context within the OHT, which is an integrated care network. So when I'm saying this, this means that I had to attend lots of meetings. Maybe that has nothing to do with evaluation. And you can think all the way from provider to provider interactions like rounds, for example, to create a care plan, or all the way up to strategic planning initiatives at the steering committee level. I was looking at all of these. I also need to create lots of tools, because the tools that are already in the research, or like they were available for us, weren't always a good match for the need of the community. Also, I learned that data is more than just number or codes. Context and understanding the context when you are collecting the data, analyzing the data, and presenting the data is very important. I also learned that engaging with patients and caregivers in the evaluation process is important. And after that, I start using the results of the evaluations to promote for the programs, something that I would have never thought about in the research environment. I used this to request funding. I used even the evaluation results to kind of negotiate the reporting requirements. But the most important piece is that the evaluation results were used to rethink the programs. And in some cases, it was to redesign some of the programs. And one thing that I was very happy to do, which is sharing knowledge. So I would share the tools and the frameworks that we're using within the BOHT with other OHTs. And I'll come to this later in my presentation. I also came to realization that the most interesting aspect of evaluation is actually getting the chance to implement the results of the evaluation and live the transformation firsthand. So I became for the first time involved in design and transformation. And I became, after I finished my first year, which is the OHT Fellowship, and I became hired with the Burlington OHT, my title actually changed from an evaluation lead to population health management and evaluation lead. What this means that I am planning, designing, also doing this connection between senior leadership and operations, plus my evaluation work. I also started to feel more and more of the ownership of the transformation. I started to again feel more about this embedded feeling. I'm now part of the team. I am part of the transformation. I wanted whatever I'm doing to be shared and shared widely. What I'm so proud of right now, after 2.5 years with the Burlington OHT, is that I was able, after all these learnings, to become a change agent within my OHT and across other OHTs. For instance, I just counted how many public engagements do I do, and I found like in the last 2.5 years, I probably did 30 public engagements every year. Also, my tools that I created for the Burlington OHT are now used in Durham OHT, are used in the OHT West 15 OHTs for a program called the LEGO program. And another suite or an evaluation plan and suite of tools that I created for one of our programs that is called the Community Wellness Hub, which is a NORC for seniors, is actually also used in the Connected Care Halton OHT. And it's going to be very soon also used in the Hamilton one as the program is, or the model of care is expanding. I became an evaluation consultant on so many provincial and regional tables, even though it's not like an actual role or like a paid role, but I'm happy to do that all the time because this is where I feel my value, which is the connection between a research background, a research mindset, but also understanding the local context of the OHTs and how can we connect the best of both worlds. So I am, again, an evaluation consultant, for example, for the OHT engagement framework that kind of describes and formulate the relationship between the Ministry of Health, OH, and OHTs. Working with the design component when I became a population health management role, I started to understand a lot about EDI, equity, diversity, and inclusion, something that I wasn't familiar with before. And I started to use this principle in the planning of the program, also in the evaluation of the programs. And that's how I got invited to the HEAT table, which is the equity table at OH West table. And I'm now their evaluation consultant as well. And we just released a survey that I believe some of the OHT folks on the call would have received it like last week or so. However, I didn't forget my academic background. So I still collaborating with my mentors, Dr. Kerry Kolosky and Dr. Julia Abelson, in lots of the work that they're doing in collaboration with the OHTs. I'm very happy that whenever now people are thinking about someone who would be able to connect research and OHTs, so I'm one of these people, so I'm very happy because that's exactly where I want it to be. Because I'm a qualitative researcher, I can't leave you with some quotes. And because I'm an evaluator, these quotes are about the impact. Back to the change agent perspective, this is a blurb from an email that I received last night. It's kind of thanking me about a dashboard that I created for a program run by this community agency. I would say that for the first year and a half of my work with the Burlington OHT, my perception at this particular agency wasn't the best because I was seen as the demanding evaluator who asks so many things of the team. But now, after this relationship has evolved and I learned a lot, and they now knew that I'm not here to judge them, I'm here to help them and support them as much as I can in order for us all to showcase the impact of the programs that are being designed and implemented and run by the Burlington OHT. Because I'm very happy about this email, so I wanted to share it with you. So what are the secret ingredients in my perspective? Leadership was key. There was no way that any of these things would happen if there wasn't a very supportive leadership at the Burlington OHT who supported me to do whatever I needed to do actually to get this forward. Putting my name forward for any table who wanted to do some evaluation work. Kind of sharing my knowledge with everyone they know. This created this local community of practice who knows what evaluation is, the importance of evaluation, how to create tools and share tools. Adaptability is another secret ingredient because, again, the context of research is pretty different from the research, from the practice environment and context. So whenever researchers became embedded, I think that being adaptable and flexible is very important. Mentorship was a key component in all what I've done. The culture that would encourage you to do what you need to do and to support you even when you fail was very important. And also the last secret ingredient I would say that I've learned across this journey was knowledge is multi-directional. Don't assume that because you come from a research background or a research position that you hold all the knowledge. Knowledge can be sought everywhere. You can talk with a patient and get some knowledge. You can talk with a caregiver, a provider, all the way till CEOs of hospitals. Seek knowledge, whatever it is. Thank you so much.
Thank you, Rayam. And so now we have a few minutes for questions. So if there are any questions, if you're on Zoom, pop a question into the chat, and if you're here, then raise your hand, and we have 5 minutes or so for questions for any of the speakers from today. Okay. Dear,
Oh, right.
yeah.
Good afternoon, everyone. I have two questions, if you would allow. Two for the session presented. Great presentation. A couple of things. I was wondering if you can not touch the wall so that I from the top. If it was by this slide, some of these boxes. Maybe I missed the also. What was some of the indicators that you put together that you share?
That's her short list. But in terms of domains, so in terms of overarching domains, it's very OHT specific. So it would be we definitely had Dean throughout, so we both had to put the how so we had to that out. But I would say the indicators themselves.
Could I ask the presenters to come up to the front? It's a bit hard to hear. I know, just because there are people from who are listening on Zoom. So the last question, they were just some questions around the indicators, and I know that Grace and Brianna are going to be sharing the toolkit, which will have like the more detailed explanation of the indicators, but maybe just to, if you want to quickly repeat, Brianna, repeat the answer to the last question, and anything else you want to say about the indicators?
Sure, yeah. So the indicators themselves, but maybe I'm not understanding the question correctly, but the indicators themselves that we had collected from the organizations were between us were very organization specific and unspecific to the OHT. In terms of mapping them out, we did have common themes: social determinants of health, neighborhood utilization and service utilization, provider and patient experience, specific provider outcomes. So a lot of organizations were tracking specific provider outcomes, and then I'm sure I'm missing some health outcomes and health behaviors, so tracking along. So those were some of the key ones that come to my mind at the moment.
And then I would just add that, so in addition to sharing these fillable templates, we'll also give examples of just the first rows filled in, just to give you a sense of some of that, because I know that was helpful in Brianna and I working together, just understanding what we meant by frequency of reporting, that we would write in quarterly or annually or these types of things, or in terms of an indicator name versus definition, just getting some consistency there. So we'll be providing examples that we filled in, as well as the fillable templates themselves. So that should be really helpful in you taking the tool forward.
The tool will be coming in a future webinar.
Yes,
Right.
be launched. Rob.
Hey folks, thanks for your presentation. My question is first to Sophie, but then to everyone. Sophie, you talked about concern about your work not being able to get into depth. So my question to you is, what sort of investigation can you do for structures to continue it, if any? And how would you plan?
Very good question. So we did reach out to partners in the Northwest. Well, just especially because like NOSM is now I mean, it's always been a pan-northern institution, but just with its bona fide status as a standalone university, we did reach out to them. Admittedly, I don't know where that landed, but that was something that that was of a bit concern, because these research projects were in process, and once my time at U of T was up, access to the library was gone, databases were gone, access to one research ethics board was gone, which is why the partnership with Algoma was particularly important. And although while our colleague at Algoma is involved in a lot of OHT work, formally from a project standpoint, it was project specific involvement as opposed to just a blanket use the REB at any time. Like, she had to be intricately involved, particularly as like a listed PI on a project for those applications. So that's why I really tried to focus initially on collaboration between the health and education and research sectors, to try to make sure that even as like the resource of the embedded fellow was removed, that there would be some stability.
I think, yeah, you definitely highlighted a challenge, Rob, and the sustainability after fellows leave. I think for me, I really tried to spend time resourcing my OHT in the best way I could, just making sure that they were aware of resources available to them, the RISE coaches, the OH data dashboard, how to use the tool, how to download data, how to interpret, to a sense, some of this data. And then along the way, just be sure that I was vocalizing some of the process steps along the way. So really sharing about setting objectives early on, setting metrics associated with those objectives, how far that can take you in evaluation later on, and just kind of trying to create that culture of evaluation and quality improvement, and resourcing where I could.
It's following on that lines of
Okay.
sustainability. So my name is James, US Scarborough OHT, and one of my questions for Grace and Brianna, with regards to the sustainability of the data dashboard afterwards. So assuming part of it is utilizing regional data that's available through the dashboards and whatnot, and then other data collection was from the OHTs is collection and combination of localized data sets as well. Within Northumberland and area, how did it work in terms of setting up resources within the OHT to maintain that data collection from OHT partners? So was there an individual assigned in the backbone of the OHT that's responsible for collecting it and then putting the dashboard together on a regular basis, or did one particular organization say, we have capacity, we can keep this up and running afterwards? Because I know that when we're doing implementations and whatnot, we want to probably have refresh data every few months from our partners, and I think that's a struggle that we're having, is the sustainability with everybody being stressed in their own organizational specific roles.
Yes, and I wish there was a good answer to that question, but that's
the question for online, maybe a summarized version of it if they're not hearing.
So the question in the room was, thank you. The question in the room was around sustainability for online tools such as the data dashboard or even the data repository, because you really need backbone staff, or it can't really be done off of the side of the desk. Somebody has to take it, and the whole point of it is for it to be dynamic and to follow the strategic priorities of the OHT as that shifts, so that it's a small group of data points. So I guess the key there is having it be a very small set of data points that's very relevant, that's easy to grab, and that you have somebody somebody assigned to that can grab it from the repository. So the idea behind having the repository first is that it's already there. So organizations are already feeding into it. So you're grabbing the dashboard from data points that are already there. So it's a quick put onto the dashboard, but you have to have the mechanisms in place in order for that to be achievable. But that is a huge barrier, absolutely.
And then I would just add on to that, that this is the idealized version of what data integration looks like, given our perspectives and experiences, but neither of our OHT reached the actualization of a live data dashboard or repository. Both of us made it to different stages along the map and have a quest forward.
They're there. They're the,
But
yeah.
yes,
Yeah.
that's the goal.
Yeah.
So much. Hi again. I don't mind, you don't mind me double dipping. On the issue of sustainability, I'm going to direct this to Rhea, if you can hear me. What sort of tips we can give, you know, as current fellows looking to navigate this current experience in the future as an option of being embedded into the OHT after this fellowship experience? And if you could sort of speak on some resources that we could rely on to build our skills in evaluation.
Repeat it for Rayham.
Rayham, did you hear that?
I'm sorry, I'm not able to hear well. So would you please repeat it for me?
Okay, yeah. So the question from the floor was, if you, from your experience, and please correct me if I get it wrong, but from your experience, what are some tips that you have for the new cohort of Impact Fellows coming in for being truly embedded and engaging in that sustainable role? Did I?
Yeah.
Okay.
Okay, thank you so much. I would say avoid my mistakes that I did at the beginning, which is focusing my work on just like one project or one part of the OHTs. Try to understand the context of the OHT as a network, as a policy change, as a system transformation. Once you position yourself in this space, other than I'm a researcher, I'm here to do a research, you're gonna start like being able to locate yourself within a more sustainable not just role, but like understandable role. Like people will know why are you here, what is it that you're doing, and how to take this forward. This would be my first tip. The second tip, it's always better to build a team than a unicorn. So try to always, when you're working with the OHT, try to leave a footprint wherever you are. You do have knowledge, and they do have knowledge, as I mentioned earlier. Try to find these intersections and build your space there.
Great. Can I have thank yous for everybody? Thank you very much. And thank you to all our attendees here in person and on Zoom. We are recording this, so we will have the slides available and recordings available later. And just for anyone who is interested in the OHT Impact Fellows Program, feel free to reach out to the program team or go visit the website at ohtfellows.ca. Is that what we are? I should know it. We look forward to seeing you at a future event. We will be running several webinars in the fall as part of our Lunch and Learn series. One of those will be, in fact, you'll hear again from Grace and Brianna, who will be doing a walkthrough of their online tool. So stay tuned for more details about that. And thank you all for joining us again. Have a great day.